So my name's Dina Stewart-Butler. I'm the manager of the Aboriginal Family Birthing Program here and manager of Strategic Operations Aboriginal Health Division at Women's and Children's Hospital here in Adelaide. But more importantly, I'm an Arabana woman from the Lake Eyre region of South Australia. My Arabana name is Barala, which means moon. I like to think that I bring light to the darkness and it's a really important role that I think that I have here in hopefully changing the way our non-Aboriginal clinicians work with our people and constantly think about them at the forefront. I was an Aboriginal health worker. I started in 2000 as an Aboriginal health worker for Pickawee Health Service in Port Augusta. Grew up there, for about 30-something years. Dad moved there from the railways when I was about 10, and previous to that I worked for TAFE, so education, and then started with health. So then in 2002 I started working with Child and Youth Health in partnership with a child health nurse doing baby health checks. So that sort of, fueled it, and I thought, I don't think we're even starting early enough here. We need to go back into pregnancy to make a difference, because I can see even then there wasn't a lot. I felt we could do more, particularly in pregnancy. So the opportunity came then in 2004 to apply for one of the AMIC roles. There was myself and just another Aboriginal health worker, two of us. We were called antenatal workers at the time at Pickawee Health Service. And Bronwyn stayed with Pickawee Health Service, and I put my hand up to work up at the hospital. And we started the program there with two of our midwives, fantastic midwives. Bronwyn and I were very, very fortunate to have Anne and Cheryl. So from there, basically, I stayed on, and then for about 7 years worked clinically for the program, and then there was an opportunity to do the team leader role, because by that time the program expanded across country. So they needed a senior AMIC practitioner to go out and support the Aboriginal health workers. At that time we had about 22 within all the programs, so I would go out to, travel out to Sojourner, travel out to Port Lincoln and go and see all these health workers to support them. And then I did about a year as just filled in as a manager for the Aboriginal Health Division at Port Augusta Hospital. And then I had relationships, because I kept coming down here, and because I was training some of the AMIC workers that just started down here. And I had basically asked, Dina, we're going to put up this position, we need a manager, we'd like to set up a model. Any chance you're interested in a redesign down here at Women's and Children's? So I put in for it and won the position. So I think it was like in 2000, around that time. I know there was a lot more work done previous to that, but in 2000 it was, I think, a real starting point. Up until 2002, there was consultations that happened across South Australia. A lot of women were concerned about, particularly the number of caesarean rates, the number of our women that were coming into hospital and not having any antenatal care. Our babies born small, and there was lots of issues around maternity care. So our women were aware of it, even though they couldn't put the names, perinatal statistics, how, I guess the health jargon or words around it. We knew that something wasn't right. So out of those consultations there came some key things that our women wanted within South Australia. Some of those things were Aboriginal women caring for Aboriginal women. They wanted to see that we didn't have to continually explain who we were as people, that there was a cultural connection to somebody when they came into these hospital systems, but also understood where we were coming from, and how important that is for us. It's at the centre of us. It wasn't just about maternity care, but the whole person, so that was really important. The second thing was, again, working, they still had a great respect for midwives, and from the nanas we spoke to, there was a lot of history around midwives. I know even within my own family, traditionally, there was Aboriginal midwives that took care of our women. So they were, looked upon as important people to be part of this. The other thing was, because of all the high risks, they still wanted to be connected to the hospitals. So there wasn't really a push for them these models to be in community control so much, but mainstream hospitals, because of the high risk, and even our women were aware of that. And also the culture and the woman had to be at the centre, continuity care of model. So they were the basic, principles around what came out of the program. So what we did was actually put in a small amount of money, Commonwealth money, and we started in Port Augusta in 2004. And it sort of started from there. So we've got 6 Aboriginal family birthing programs across country, South Australia.
Fantastic.
And we've got 2 here in Metro, so one here at Women's and Children's, and there's another one out at Lima Kewan Hospital. So, and basically it's about caring for women that come in through this program. One of the things that we've done here at Women's and Children's is because there's 8 different units, it's not all one maternity ward like the smaller hospitals do in country. A woman can usually walk in and you can see everybody on one ward. This hospital, it's been a lot more challenging, but a good challenge. And I think the encouraging thing is this hospital's really supported this model. We've got amazing doctors, and you know, the CEO's been fantastic. Our executive directors have all been very supportive of this model, and it sits under the Aboriginal Health Division, led by a fantastic director, Jackie Arkit. So, and I think the great thing is because we've had that support from the top, it's being able to filter down and we've been able to do what we needed to do the right way. So some of the little things that have been really important, particularly around engagement, we know if we haven't got them in the first 2 minutes, they're not going to come back. So we do midwife and AMIC work triages. So here in Metro, they will ring up and say that they're pregnant, a woman, that's how they make contact. And then they're referred, depending on where they live. If they're birthing here at this hospital, they come through a triage process. So it's the first antenatal visit, which usually takes about an hour and a half. But with Aboriginal women, the AMIC worker and the midwife are present, and they introduce the birthing program and the support that they'll get through that. And so often then those women come into our program here, and then we'll do the rest of their visits up here on antenatal within the hospital.
Right.
So being strategic about where do we need to put our people, what do we need to change around, you know, how we do policy, how we look after our families, around engagement, consumer engagement, and a lot of that quality and safety stuff. So that's been a really important role, because it's about changing, and this is why I wanted the program here. If we're not in mainstream hospitals and not being seen about what we can do, the culture doesn't change. I think it changes better when we've actually got programs within mainstream services. They can see how our health workers work, they can see that we can manage, they can see the work that we do, that it actually has a filtering effect and influences our clinicians. That, you know what, we need Aboriginal people in these mainstream services to make a difference for our families. So I just think it's really, 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 really important, you know, because I think sometimes, I mean, I come from community control, that's where I started as a health worker, and I think they're very, very important. But, you know, if most of our women birth within a hospital system, they have to birth here, there's no choice around that. Well, it's these systems we need to change. So we need to have our people here. And that's why I'm all for it. We've just signed off on scope of practice, you know, clinical governance, framework that this hospital actually supports. We're working on, you know, like I said, our workforce framework for this hospital so that we can actually employ Aboriginal health practitioners. So we need to start thinking, I think that's the way we need to start thinking, because if we continually stay out in community control, these big mainstream services that service our health of our people, because majority, when I'm talking about maternity care now, majority of our women, because of the maternity high risk, have to come to hospitals. So I think it's just, there's this other work that happens that we're not aware of about, you know, making change. You know, we're talking about a handful of Aboriginal women working in a huge, you know, machine like this hospital. It's, you know, you're a minority group. Yeah, so it's a constant struggle or a constant fight of keeping this model and this way of thinking and how we do business with our families on the agenda constantly and at the forefront of everybody's mind.
Yeah, how about doing that?
Well, a few years ago, there was a resource development group that actually developed a nationally accredited training course for Aboriginal maternal infant care. So it was a bit like, you know, the old Aboriginal health worker certificate, you'd get that clinical, but then you'd have specialised pathways into childcare or whatever. So this was into maternity care. So we designed that here in South Australia. At the time we looked at some of the other states. A lot of the other states had maternity care specialised areas, but not clinical. So we wanted to make sure that we had clinical incorporated into that. So we did. So our registered training organisation is Aboriginal Health Council, South Australia. So we set up a nationally accredited training course. It takes about 18 months. So it's a bit like a taste of becoming a midwife, because they actually have to do follow-throughs. So you do 10 follow-throughs to really look at what normal pregnancy is, or complicated pregnancy. So that means once they're qualified, they can actually do a palpation to feel where baby is, to measure fundal height, to see how baby's growing, to check fetal heart using a Doppler to make sure that baby's heart rate's right. And so because they've already got, they know how to take a blood pressure, they know how to do a urinalysis. Basically, that's all the clinical skills you need to actually do an antenatal check. So it's designed in a way you actually need to be employed within a model of care.
Okay.
Because it's too difficult around placement. I mean, as you can imagine, to do 10 follow-throughs, you need 18 months. You wouldn't get a placement for that, so you actually need to be employed into a birthing program. So what at the moment at Women's and Children's now, when we advertise for a position, we're looking at AMIC practitioners to employ them. So they could have their Cert 4. They don't necessarily have to be registered, because we can work on registration through ARPRA once they're here, and then they can do their training. So that's the other really important thing that we have as part of our model, is we have a midwife educator that's attached to our role, our program. So she will help train and fill the gap for that AMIC worker or that health worker. But honestly, I think this is the model for all Aboriginal women nationwide, if we really want to make a difference. And some of the findings that have come out of the Aboriginal Family Study and the research that's been done with regards to this program is that we are making a difference. We are, our babies are getting fatter, birth weight's been improved. I mean, we're well and truly over the, 5 to 7 antenatal visits that we never had in 2004. Those antenatal visits are happening now. And we know when you work in this space, if we can actually get women coming regularly and having antenatal visits, we're more likely to pick up things earlier. We're more likely to actually improve on outcomes for mum and for baby. So just that in itself has been fantastic. And I think, just being able to have those conversations and build those relationships has made a huge difference to women here.
It's fantastic.
Yeah.
Good work.
Yeah,
and congratulations.
Thanks very much.
Yeah.